You are ready for me to take roll call, just let me know.
Yeah, I'm ready. So welcome to the Alcohol and Drug Policy Commission meeting today. I am going to chair the meeting because Chair Vecina is absent today on an excused absence. So with that, Jill Gray will do the roll call.
Yeah, I'll just start at the top. Commissioner Cruz. Commissioner Mazziotti, and I'm so sorry, everyone, if you can hear something in the background. Both my husband and I have competing work meetings going on at the same time. But let me try that again. Commissioner Mazziotti. Commissioner Holton. Commissioner Archer. I see you.
Present.
Commissioner Hupy.
Present.
Commissioner Minty. Commissioner Godwin.
Here.
Commissioner Gowran.
Present.
I got you, Nate.
Okay.
Commissioner Clarkson. And then Chair Vezina is excused. Commissioner Nordyke. Commissioner Obiero. And then for Senator Solomon's office, Nicole, I think I saw you.
Yes, here, Jill, thanks.
All right. Representative Reynolds' office. I'm not sure I saw anybody. All right. And then I know we have quite a crew of people from OHA today, but is there anybody who's attending today who's representing the Behavioral Health Director? And that may be a no, because I know she's not coming on board until Monday, I believe. All right. And then the last one is Commissioner Biglin. All right. Nate, Tori and we will continue monitoring for any commissioners who join the meeting afterward. There isn't anything that we're voting on today, so we don't have a quorum issue right now.
Okay, great. Good to know. So first order of business is legislative session overview for 2023, and Jill's going to handle that. I did want to let the commission know that agenda item number 3, which is the commissioner roles and responsibilities, that was scheduled to be facilitated by Chair Vecina, and so I'm requesting that get placed on the next agenda for the next Alcohol and Drug Policy Commission meeting, unless there's objections. Okay, hearing none, go ahead on the legislative session overview, Jill and ADPC staff.
Yeah. One moment, everybody. Let me make a note that we're going to move agenda item 3 to next month, because otherwise I will forget. And then we can get started. Okay. So Tony and Nate had asked me to do a brief legislative update just to make sure that everybody knows the bills that ADPC is involved in and just a general overview of the legislative session. So I'm going to pull up my slides, and I apologize, everyone. After 3 years of doing virtual meetings, you would think that I am much better at Microsoft Teams than I actually am. But let me see if I can pull that up. And hopefully everybody can see a slide that says 2023 legislative session update. Okay, I got a thumbs up from Jill, so I'm going to take that as a yes. So I'm just going to move in to the first slide. I will say I was trying to figure out a way to group these bills so that they made some sense. In the first several slides, I grouped bills based on substance. And I know that isn't how we really like to view substance use policy ADPC, that we're trying to take a much higher level than really just looking at bills that are focusing on alcohol, or bills that are focusing on marijuana, or bills that are focusing on other substances. So I will say right from the very beginning, I have violated one of our principles right from the very beginning about grouping these based on substances. I was just trying to figure out a way to present them that had some order to them and that made sense. So I'll just use that caveat at the very beginning to say, I know this is that we're trying to think higher level. This is just how I was trying to organize it for today. So the first bill is, I'm sure everybody has heard about this bill. It's House Bill 2395. This is the large omnibus bill that Representative Dexter has been working on. It's a omnibus bill about opioids. I put here on this slide some of the major items that are happening in this bill, but I want to make it clear that there are actually other items going on in the bill. This is just to give you an overview, or a high level overview of what this bill is doing. So one item that's happening in this bill is increasing access to short-acting opioid antagonists, such as naloxone. So my understanding is that there are additional medications coming onto the market that are opioid overdose reversal medications. And currently in statute, it says naloxone, but this bill wants to make it very inclusive of naloxone plus whatever future medications are available. So it's changing wording from naloxone to short-acting opioid antagonists. But one of the major things it's trying to do by increasing access to naloxone is make it very clear in statute that first responders, so firefighters, paramedics, police, that they can administer naloxone and that they can distribute it. So in other words, they can leave behind kits. So it is now going to be, if this bill is to pass, and it is expected to pass, very clear in statute that first responders can administer and distribute naloxone, or I'm sorry, short-acting opioid antagonists. The bill also would make it so that school personnel can administer naloxone. Currently, school employees cannot administer a medication without a parent's written permission. Even in emergency situations, this bill would say that would really create an exception and say that a school personnel can administer naloxone. So it's really, and there are a few other ways that this bill is trying to increase access to naloxone, but one of the major focuses is trying to make sure that those people, those professions have a way to administer naloxone. The second big item that this bill does is it decriminalizes fentanyl test strips and other harm reduction supplies that reduce injuries, illnesses, and overdoses. I think everybody knows that currently in Oregon statute, fentanyl test strips and some other harm reduction items are considered drug paraphernalia. This bill would remove fentanyl test strips and some other items like pipes from the drug paraphernalia statute. The issue that ADPC had, and Representative Dexter was very agreeable to this discussion, is that it shouldn't just decriminalize fentanyl test strips, but rather take a bigger, broader public health approach, meaning those items that reduce, as you can see, injuries, illnesses, and overdoses, those should be removed from the drug paraphernalia statute. She completely agreed, and the wording in the omnibus bill, it does contain this larger public health focus of trying to take out of the drug paraphernalia statute those items that would reduce injuries, illnesses, and overdoses. So we were very happy about that. A third major area that this bill has in it is reducing barriers to minors seeking treatment for substance use disorder. So the bill would say, I believe it's if you are 14 and over, you can receive outpatient treatment for SUD without parental permission, without notifying a parent. And other people who work in this area probably know this better than I do, but I think that that is equivalent to what is on the physical health side, that someone who is 14 and over can receive treatment, can receive services for physical health without parental notification. So I think it's trying to align up both physical and behavioral health. But regardless, the bill would say that if you are a minor, you can receive outpatient services without parental notification. And the last major item is this bill's trying to establish some protocols and timelines for reporting of opioid overdose deaths. Originally, Representative Dexter had a pretty robust section in her omnibus opioid bill having to do with opioid overdose reporting, but that was going to contain a fiscal. So in other words, it was going to cost money to implement that. Representative Dexter is really trying to keep this bill out of Ways and Means so that it goes through the legislative process as quickly as possible. So she really pared down this section having to do with reporting. Currently, the bill says that OHA is going to give guidance to entities like the local mental health authorities on reporting of opioid overdose deaths or suspected opioid overdose deaths. Sorry, that's a little bit of a tongue twister. And then the bill kind of just leaves it there that we're going to try and have better uniform reporting, but the guidance is going to come from OHA. This bill had a work session yesterday in the Behavioral Health and Healthcare Committee, and it passed out. So it is on its way to the House floor, and it is. I hate to say halfway through its legislative journey because anything can happen and I don't want to jinx it, but it is pretty far in its legislative path. That was a lot of information about that bill. I actually, since we have quite a few bills to talk about, I'm going to pause since this was a big one and just see if there are any questions about this opioid omnibus bill. All right. And of course, as always, if anybody thinks of questions after the meeting and you would like to talk more about this bill, you can always reach out to me and I'm happy to talk to you about it. But we're going to move on. And the next bill that we have been engaged on over at the legislature is House Bill 2516, and this is a cannabis bill. The cannabis industry had a legislator introduce really a package of bills for them. There are, I believe, 3 bills. This is the bill that I think is the most concerning, and so this is the one I put on this slide. House Bill 2516 would really increase access to marijuana, and you can see that it does a few things like it allows small scale producers to sell marijuana items directly to consumers. It permits delivery to a hotel or inn. And it also allows a wholesaler to sell or trade marijuana items with retailers at like trade shows. So from ADPC's perspective, this increases access to marijuana. I am not an expert on the regulatory structure of marijuana, but in a very high level way, we do have a system here in Oregon where there are wholesalers who then sell their product to retailers and retailers sell their product to consumers. This would allow wholesalers to sell directly to consumers. So it would bypass the system that we have right now. It also there's concern about delivering items to hotels and inns could possibly violate our Clean Indoor Air Act. So there are multiple concerns about this bill. I have meetings with a few legislators who sit on the committee where this bill is being heard, and this bill is not being heard in the Behavioral Health and Healthcare Committee. It's being heard in the Economic Development and Small Business Committee. So it's a different set of legislators, some of whom we have not worked with a whole lot in the past. But I have been trying to reach out to those legislators and just let them know in a very neutral state agency way, because we do not have permission to take a position, but rather just let them know that this bill has some conflicts with our strategic plan, which very clearly says that we should not be increasing access to marijuana. This bill had a hearing already. So far, it is not scheduled for a work session, but I will be keeping my eye on this one and continuing to reach out to legislators about it. So on the cannabis bill, again, I'm going to stop and just see if there are any questions about it. All right. And then we will move on to some alcohol bills. I'll just preface this by saying I've put some highlights on this slide, but there are other alcohol bills as well. These are probably some of the major ones that we're working on. First one is Senate Bill 616. Oh, I'm so sorry. That's not right. I don't know what happened to that slide, but let me tell you what 616 actually does. 616 allows direct shipment of cider and malt beverages. So in other words, cider and beer, and it goes up from 2 cases to 5 cases. So it's an increase in the amount of cases a shipper can ship to a consumer. We have seen actually some of these types of bills excuse me, in the past where it has involved wine. And this is the way that the alcohol industry is phrasing this bill is that it is a parity with wine. So in other words, wine got to go up from, I think it was 2 to 7 cases. And so beer should be able to go from 2 to 5 cases as well. I find these bills really difficult to talk to legislators about because each little individual item may not have a huge impact, but when you take them all together, there has been quite an increase in access to alcohol over the last 2 legislative sessions. So we have been continuing to talk to legislators about how each individual bill may not be a huge amount of increase, but when you take them all together, this has been quite an increase to access to alcohol. And it's a hard conversation to have with legislators. I will say that this bill, it has already had a hearing and work session. It is passed the House and it is actually now in the Senate. So it is really kind of flying through the legislature. And I'm so sorry. These I'm gonna stop my slideshow just for a second. Because there is something wrong with those slides. Let me see if I can get the right slides up. And if not, that's totally fine because I can do it off the top of my head. I have done this so much.
Go Jill.
That sounded like Dawn. Is that Dawn?
Maybe. Dawn, did you have a question? And I'm so sorry, that's my toddler in the background in case anybody can hear her. Daycare is closed today, so my toddler is home. All right. Hold on for 1 minute. I need my IT support. So everybody hang on for 1 second.
And now you're gonna have to manually switch over to PowerPoint. Then I'd confirm that everybody can
Right.
see.
Now I can't see anybody, so somebody has to tell me if you can see my slide.
We can
Yes.
see your,
You
Good
can
job.
see it?
yes.
Okay, great. Thank you. All right. So we already talked about 616. The next one we're going to talk about is House Bill 3308. 3308, and this is the bill that last month, if you were here for our meeting last month, Jess Nyworth from OLCC came in and talked about this bill. And she talked about there was a project that OLCC did having to do with alcohol delivery, and that one of the legislative concepts they were thinking about was having an alcohol delivery permit program. This is the bill. This is the bill that she told us about last month. So House Bill 3308, as you can see, authorizes OLCC to issue delivery permits to applicants to deliver alcohol beverage. House Bill 3308 was just introduced. In fact, I believe it was just introduced into session 2 days ago. So it has just been referred to the Behavioral Health and Healthcare Committee. There haven't been any hearings, nothing yet on this bill, but this is one, again, in a neutral state agency way, that we would be very supportive of because it supports the strategic plan. The next one is House Bill 3312. And I think everybody on this meeting has heard that Oregon Recovers is working with Representative Sanchez on an alcohol bill that's not really an increasing alcohol taxes bill, but having to do with alcohol revenues. This is the bill. It's House Bill 3312. And again, you can see it requires Department of Revenue to study revenues received by state from transactions involving alcoholic beverages. And again, this bill also was just introduced, I believe, on Tuesday and was just referred to committee. So there haven't been any hearings on it, nothing like that yet. But this is another one that as ADPC, we would probably be very supportive in it, again, in a state agency neutral kind of way. The last one is cocktails in a can. We've heard again and again that the alcohol industry is going to introduce a bill about cocktails in a can. Cocktails in a can would be allowing for cocktails in a can to be sold through grocery stores or convenience stores. And that is a concern to us. Again, it would be increasing access to alcohol. But yet none of us have seen this bill yet. Since we're getting to a deadline of when bills could possibly be introduced and actually having anything happen to them. We may not see cocktails in a can this session. I kept it on here just because I'm keeping my eye out for it. And even if we don't see a bill this session, it seems to be a recurring issue. We'd probably see something about it in a future legislative session. So those are my alcohol bills. And again, I'm just going to pause and see if there are questions about the alcohol bills. All right. And then everybody's favorite subject, ballot measure 110. So the first bill I'm going to talk to you about is House Bill 2089. House Bill 2089, I feel like it can get complicated quickly. So I'm going to do my best to explain it to you. And again, if this is one that people would like to talk about more, you are always free to email me, call me, and we can talk about it. So let's see if I can explain this as succinctly as possible. The way that ballot measure 110 works is that there is a distribution formula for marijuana revenues, and every quarter there is an amount, it is, I believe, 11.25 million that is distributed through this formula. And then everything above that amount, it goes to ballot measure 110, and that is what the Oversight and Accountability Council uses to disperse grants to the Burns, to Access to Care grants. This bill would change the cap. It would increase the amount that would go to the distribution formula, which means there would be fewer marijuana revenue dollars going to the Oversight and Accountability Council. I think a lot of people on the Oversight and Accountability Council are very concerned about that. First of all, it would mean fewer dollars coming to them to disperse out to grantees. But the second thing I think they're really concerned about is the revenue forecast came out yesterday or the day before, and part of the revenue forecast says that we are expected to see fewer marijuana revenue dollars in general. So I think a lot of people feel like that's a double hit to ballot measure 110 grantees. But as if that weren't enough that this bill is doing, the House Bill 2089 would also make changes to the distribution formula. So currently that first 11.25 million that is dispersed through the distribution formula, there's a certain percentage that goes to cities, a certain percentage that goes to counties, a certain percentage that goes to state police. There's also a certain percentage that goes to the Oregon Health Authority. And what this bill would do is really wipe out, it would zero out that allocation that goes to the Oregon Health Authority, and it would increase the percentages that go to cities, counties, and state police. For ADPC, that is very concerning because among the things that OHA does with its allocation of money is some prevention work. And this is actually one of the few state investments Oregon makes in prevention work. But if this bill were to pass as it's currently drafted, it would wipe out that allocation to OHA. This bill has already received a hearing, and it is in the House Revenue Committee. For ADPC, we submitted testimony expressing our concerns, and I have been talking to legislators who sit on the Revenue Committee about our concerns with House Bill 2089. After today's meeting, I'm happy to send out to everybody the testimony that we submitted so you can see what ADPC said about House Bill 2089. It currently is not scheduled for a work session, but of course there's still plenty of time when that might happen, so we want to keep talking to legislators about our concerns with this bill. The next bullet point you can see is the ballot measure 110 work group. So I lost count of how many bills were introduced this session that have to do with ballot measure 110, but there were a lot. And the chair of the Behavioral Health and Healthcare Committee is Representative Nose, and he has pulled together a work group where he wants to talk about statutory changes for ballot measure 110. And in this work group, if this makes sense, there are lots of changes people want to make that are operational changes. So like how OHA interacts with the Oversight and Accountability Council. But what Representative Nose is really focused on are statutory changes, and I think that makes sense. He has an opportunity to do a bill that would change statute to hopefully improve ballot measure 110. So he's really looking at statutory changes. And if people want to get into even more detail about what those changes might be, he has said multiple times the framework he's using is the Secretary of State's audit of ballot measure 110 that just came out maybe about a month ago. And he's really using that as his guiding document for this work group. So today it meets every Thursday morning, and this morning we talked about what are some measurements and metrics for ballot measure 110. And the conversation is going to continue for about another month. So I just wanted to put this on here to say there's this whole big work group. ADPC has a seat at the table talking about ballot measure 110, and we will most definitely see a bill come out of this work group. So there will be some changes happening this session to ballot measure 110. So those are two big items for ballot measure 110. Are there any questions about either one of those two? All right. And then I just want to make sure commissioners know there is one bill that was introduced this session that does mention ADPC. It is Senate Bill 238, and you can see right here what it says is going to happen. It's going to direct OHA, the State Board of Education, and ADPC to collaborate on developing curricula supplements related to dangers of certain drugs and to laws that provide immunity or other protections related to drug or alcohol use. When you go into the bill and read it, it is very clearly targeted to fentanyl. That the sponsors of this bill want these 3 state entities to work on developing curricula supplements related to the dangers of fentanyl. I have to say that none of the sponsors, none of the legislative sponsors of this bill have reached out to ADPC to get our feedback on this bill. I think it's fine if it passes, but we really haven't had much involvement with this bill, even though it mentions us. There is a hearing next week on this bill. And again, if it passes, it's fine. I don't have an objection to it. It's just that we haven't had a whole lot of involvement with any of the legislators who are working on this bill, even though it mentions us. I actually just have one slide left and then I'm all done. And if there are any questions, we can take them. As everybody probably remembers, the governor, she is required to submit a budget, and she did that at the very end of January. And it's a long document. I've put on this slide just a few items out of the governor's recommended budget that have an impact on our work. And here are those items. So the first one is the governor's recommended budget maintains existing investments in behavioral health. So I think everybody will remember the last 2 sessions, the legislature has made substantial investments in behavioral health through increasing reimbursement rates, providing workforce incentives to grow and expand the workforce, and a variety of other areas. Her budget is maintaining all of those investments. The second thing is there was an allocation in the governor's recommended budget to the harm reduction clearinghouse that OHA administers. I have a feeling most everybody has heard this, but just to be sure everybody has, the clearinghouse does not have funding beyond, I believe it's another month. And it has been a really great thing to have this clearinghouse. The clearinghouse distributes not only naloxone, but other supplies out to organizations and to local governments. And everybody has said that this is a successful operation and they want it to continue. In the governor's recommended budget, she allocated $40 million from the opioid settlement revenues to the harm reduction clearinghouse. And there has been a lot of talk and I think actually a lot of spiraling on this allocation. So there's some problems with it. The first of which is the opioid settlement board doesn't have to do anything that the governor's office tells them to do. But the second thing is at the state wide level, there isn't, so the governor allocated $40 million. There isn't even $40 million currently in the state opioid settlement account. So there are some problems, some questions about this allocation. But I guess what I would tell commissioners is that the governor's recommended budget is really signaling to the legislature some of the items that she wants them to consider. These are priorities for her. And even though the allocation itself may not work out, it's still a signal to the legislature that the harm reduction clearinghouse needs to be funded. So there'll be lots more discussion about the clearinghouse, and I'm happy to report back to commissioners what's happening with that. Third item, the governor's recommended budget set aside $15 million for SUD facilities and recovery centers. I feel like that's rather self-explanatory. So I'll go on to the last one, which is her budget also set aside $5.9 million for universally offered home visiting programs. The universally offered home visiting programs isn't a program that ADPC has been a leading advocate on. However, we have always been supportive of it. Very, very generally, the program is really there to reduce risk factors and increase protective factors, and that's what we want to see. And so we were really pleased to see that there was this allocation or a set aside of $5.9 million for the universally offered home visiting program. And again, these are just highlights. I think I'm done. Yes. Those were just highlights for what was in the what we're working on at the legislature. And here, let me stop sharing because I know that's going to be crazy for everybody. And what were some highlights from the governor's recommended budget? I hope that helps everybody have a better understanding of what ADPC is working on this session and some of the issues that are the high priority ones for us. I see that there are questions. Let me see. Or actually, I'm sorry, Nate, I should turn it back over to you.
Okay, thanks, Jill. Really appreciate the presentation. And yes, I do see a number of different questions out there. I think Dwight was first. Go ahead, Dwight.
Sorry, had trouble getting off mute there. So just a super quick observation that on that Graber bill, I think it was 238, Jill, that relates to prevention programming around fentanyl. What I've said to Graber's office is, we love this concept. We really think we ought to have a broader recommitment to prevention. And so my hope is that we can pull them in that direction, reflecting both the conversations we've had in the prevention subcommittee as well as here in the broader group. But that's it. I didn't mean to distract
Nope.
us.
I love it, Dwight. That's a great comment.
Thank you, Dwight. Catherine.
So I don't, does the governor's budget get as nitty gritty as where she would like to see the treatment facilities be? Smaller counties are definitely going to have a concern that they're all going to wind up in the Portland metro area, which makes it difficult to place out of places like Polk County, where I'm at.
Great question, Kat. And so first, no. Second of all, even though it doesn't, at least I don't remember reading anything in her budget about like geographic diversity, that doesn't mean that for this whole budgeting process going on over at the legislature, that can't be a point that's brought up. So thank you for that point, and I will remember it for budget discussions over at the legislature.
I'm not seeing any more hands, but Jill Archer has requested that you send out the PowerPoint that you just went over, if that's okay, Jill.
Absolutely.
Okay, any other questions from the commission?
And I'll just make one clarifying comment, and thank you, Jess. I said that House Bill 3308, which was the alcohol delivery permit program bill, that it was OLCC's bill, and actually it was requested by the governor. So thank you, Jess. Language is important, and it is actually a governor's bill.
All right, thank you for that clarification. Okay, moving on to the next agenda item.
Hi, I'm sorry.
Go ahead.
I'm so sorry. Hi, Nate. Hi, Jill. This is Ane. I work with an HPA on Measure 110, and I apologize for dropping in late, but I did see something about a Measure 110 work group, and I'm just wondering if that's a work group, if I can, be of any help in at all, or anything relevant to Measure 110. I'm happy to help out.
Thank you, Ane. I'm more than happy to talk to you offline about the ballot measure 110 work group.
Awesome, thank you. Sorry about that.
And Ane, where did you say you're from? Because if you say if it was Healthcare Policy Alliance, there's folks from there in the room, but I'm not sure where you said you're from.
I'm sorry. I'm within OHA, but behavioral health policy and analytics.
Thanks, Ane. Do you have Jill Gray's contact information?
Yes, we have connected
Okay.
before. Thank you.
All right, great. Okay, we'll move on to on your agenda item. It is agenda item number 4. Do we have Vicky and Alicia here for OHA ready to present?
I'm here, but Vicky is not.
Okay, are you expecting Vicky
Yes.
anytime soon? Okay.
She said she would be here at 1:45.
1:45, so we have 4 minutes or
We are
so.
so Nate and Alicia, we are slightly ahead of schedule, which I don't know how happens because we're usually behind schedule. Alicia, do you need us to wait until Vicky comes, or are you comfortable starting and then Vicky can join you?
I just got here.
Oh, great.
Is my timing perfect?
Yes.
Perfect timing, yes.
Great.
All right, you two are on. Thank you for being here.
All right. Okay. Hang on. Give me a minute to get situated with pulling up some slides here. So many meetings. Okay. All right. Elisa, you're here, right?
Yes, I'm here.
Hang on. I'm getting there. All right. Do we see a title slide? Okay. All right. Well, good afternoon, everyone. Thanks, Jill, for inviting Alicia and I to come talk to you all today about some population level data indicators for preventing excessive alcohol use in Oregon. I was looking at my notes and sort of like my historical presentations, and I think it's been about 4 years since I was last here at the commission talking on this topic. So great to be back. Again, thanks for having us today. My name is Vicki Bulow. I am the lead research analyst for the Alcohol and Other Drug Prevention Program, which sits in health promotion and chronic disease prevention in the Oregon Public Health Division. I've been in my position for about 5 years now. And I've spent a lot of time in my role, sort of like getting a lay of the land of alcohol surveillance and data indicators that are used to sort of gauge, alcohol use burden in a population. And more recently, we had Alicia come on board as our alcohol epidemiologist in our section. So Alicia, I'll let you introduce yourself and maybe give a little bit of a description for how and why you got here.
Sure. So yeah, I'm Alicia Miles. I'm the alcohol epidemiologist. Vicky sort of laid some good groundwork there. I came in because we received an alcohol epidemiology grant. So I've been here for 1 year, and I guess we got the grant maybe 5 months before I came on. So September of 2021, maybe sounds right. And it was for a 5-year grant period. And really the goals of the grant are to increase awareness of excessive alcohol use. We're primarily doing that through increasing our surveillance capacity, making more data available. We're going to be building a dashboard, but we're also working to increase partnerships and relationships as a way to increase that knowledge of excessive alcohol use. And I have been with, yeah, and what were you going to say, Vicki? Sorry.
Let everybody know where that grant is from.
It's from the CDC.
Yeah, and so, we've done alcohol prevention work in the state of Oregon for decades, right? And so, sort of in more recent years, the public health division has kind of taken on some of that, but we are just emphasizing and continuing on a lot of alcohol prevention work that has existed in the state for a long time. So as we build our capacity in the public health division to disseminate and be out there with more data and creating tools that are easily accessible to others, just keep an eye out for that, and I'm sure we'll be back to talk to you all when that happens. So. But for today's presentation, I'm just going to kick us off and go over some background and context and give a few definitions about excessive alcohol use. I'll kick it over to Alicia to highlight some key surveillance indicators and data points that we use in our shop. We'll spend a brief amount of time just talking about some of the policy solutions and framework around preventing excessive alcohol use, and we should have some time for questions and answers. So. Okay, overview and some definitions. So I always just kind of preface this and start off by explaining, what is a drink? Many of you might have heard the term a standard drink. And this is important to know what a standard drink is, because when we ask people about their alcohol consumption, we kind of use this definition to frame the question. And so the size of a standard drink depends on its alcohol by volume content, or ABV. So for example, 12 ounces of beer, that is 5% alcohol by volume, would be considered a drink. 5 ounces of wine, that is 12% alcohol by volume, and 1.5 ounces of liquor at 40% alcohol by volume would be considered a standard drink. Another way to think about it is that a standard drink contains the equivalent of about 0.6 ounces of pure 100% alcohol, or pure 100% ethanol. Note that this definition in standard is for the United States. Other countries have different standards, and there is no global standard for what is considered a drink. And just, knowing that poses quite a limitation to some of the research and the studies that are out there internationally, and even within the States about, about what the impact of drinking a certain number of drinks has on one's health. There's no standard definition of this across different countries and different literature. So that's a real limitation. So for example, in the UK, just under 1 ounce of liquor at 40% ABV is considered a drink. So the standard drink size for liquor in the US is almost 50% more than it is in the UK. And we'll come back to this definition as Alicia shows some of our data points. But sort of the key takeaway here is that, when we ask people how much they drink, this is the definition that we're using. But also at the same time, a lot of people, when we're asking on surveys, people, when they think about a drink, to a lot of people, I think it's just sort of like, what is in the container that they are consuming, right? So a container of malt beverage that has 20 ounces in it and at a higher alcohol by volume content often has, 2 or more standard drinks in it. So even though it's in one container, it is actually 2 standard drinks. And you could say the same thing about mixed drinks that you might purchase at a restaurant or a bar. So, okay. So what is excessive alcohol use? So we use the Center for Disease Control and Prevention definition, and they define excessive alcohol use as any of the following: binge drinking, heavy drinking, underage drinking, and drinking during pregnancy. We tend to focus on binge drinking because it's the most common, costly, and dangerous form of excessive drinking. And a lot of the data that we'll be looking at today is related to binge drinking. And so binge drinking is defined as having 4 or more drinks on one occasion in the past month if you identify as a cisgender female. And then for men, it's 5 or more drinks on one occasion within the past month if you refer to yourself as a cisgender male. The science in the literature is not up to speed on those who identify as anything other than cisgender males or females. And so, we would have to really think about, and we struggle a lot with how to convey this information for those types of groups. And so it's just an acknowledgement here that the science is sort of, pretty behind when it comes to this definition. I also want to point out that there are kind of different definitions of excessive drinking based on the federal organization that it's coming from. So for example, SAMHSA has a different definition of heavy drinking. So they define heavy drinking as binge drinking on 5 or more days in the past month. So even internally in the United States, there can be some variation in the definitions that are used for binge drinking, heavy drinking, and excessive drinking as a whole. But both of these definitions attempt to capture patterns of chronic use, right? So, underage drinking and drinking during pregnancy are kind of self-explanatory, but for binge drinking and heavy drinking, it's just kind of capturing, how much is being consumed on one occasion or over time. Note that alcohol dependency and alcohol use disorder isn't specifically called out in these definitions. Those who are dependent on alcohol likely fall into the binge or heavy drinking categories. However, our research shows that most people who drink excessively wouldn't be considered to have an alcohol use disorder. So these definitions describe a pattern of drinking that is very common in the population and doesn't necessarily mean that there's an alcohol use disorder involved, but there is overlap for sure. Okay, to sort of hit home again, that binge drinking is the most common, costly, and deadly pattern of excessive alcohol use. Research shows that more than half of all the alcohol that's consumed in this country is consumed during these binge drinking episodes. So that's interesting and somewhat concerning. Binge drinking also accounts for most alcohol impaired driving episodes. And again, when we're talking about binge drinking, we're talking about a pattern of consumption that doesn't necessarily mean someone has an alcohol use disorder. It's a very common behavior. A lot of people binge drink, which Alicia will get to in a second. And yes, most binge drinkers would not be considered to have an alcohol use disorder. So why should we care about excessive alcohol use? Well, for one, it drives many pressing health and social issues in our state and in the country. It is estimated that excessive alcohol use costs the Oregon economy $4.8 billion in 2019. That includes lost productivity, healthcare expenses, criminal justice costs, motor vehicle crashes, and social welfare. That comes out to about $2.40 per drink consumed in the state of Oregon. And also, decreases in excessive alcohol use is associated with decreases in a whole list of, health outcomes, health-related harms, including all-cause mortality, liver cirrhosis, crime and domestic violence, motor vehicle crashes, sexually transmitted diseases, underage drinking, certain cancers. The list is quite long, and I think not only this group, but many other organizations and agencies really should be thinking about how alcohol plays a role in the topics and sort of the outcomes that they're interested in as well. All right, I think I'm going to kick it over to Alicia now to go over some of our data indicators. Alicia, just say next slide and I'll get it for you.
All right, well, we can go on to the next slide from here and get started talking about data. All right. So briefly, before we get started talking about data, this slide gives some context for the data we're going to be talking about. And you may have seen the slides like this before, but it shows different levels of impact as you go from upstream to downstream. So upstream, you see the more community level, population level strategies and tactics. These are things like laws and policies designed to improve overall population health. But as you go downstream, you see there are also midstream and downstream tactics, and those are more individual focused. That could include screenings, medical interventions, direct social support aimed at individuals in need, and those types of strategies are also important. Our program, though, is really focused on upstream strategies. Trying to improve overall population health, trying to catch people before they get further down the stream. And with that said, that a lot of our indicators we look at reflect that upstream approach. So we look at things like number of outlets, outlet density, per capita consumption, binge drinking prevalence, alcohol-related deaths, these sorts of numbers. Next slide. We're going to start off with per capita consumption, and we can go to the next slide. Per capita consumption is an indicator of alcohol consumption among a population as a whole. The National Institute on Alcohol Abuse and Alcoholism, or NIAAA, uses sales data and standardizes gallons of beer, wine, and liquor sold into an amount of pure alcohol. And if you'll remember that a standard drink is 0.6 ounces of pure alcohol at just over 2.7 gallons per person, this equates to about 577 drinks per person over age 14 each year in Oregon. You can see that per capita consumption dipped around 1995, but rates have gone back up and rates are now higher than they have been since 1990. Next slide, please. So this is another slide looking at per capita alcohol consumption, but this time it's broken down by type, beer, wine, and spirits or liquor. And you can see that beer has historically had the highest per capita consumption. However, consumption of spirits has been increasing over time. Next slide. Okay, this chart is interesting. It's a chart looking at per capita alcohol consumption in the United States going all the way back to 1935. And you can see that it was pretty much steadily increasing. And then in the early 80s, it starts dropping. And this is because the minimum drinking age was raised to 21 at this time. So this slide is a good visualization of not just consumption patterns over time, but it also shows the impact of drinking policy. We can see, though, that the rate is starting to creep back up. Next slide. All right, now we're going to talk about binge drinking. As Vicki already talked about, excessive drinking and binge drinking specifically is common among many different demographic groups as shown in this slide. Next slide. So this slide shows binge drinking among Oregon adults by sex and age in 2021. And you can see men engage in binge drinking at a higher rate than women. And those ages 18 to 34 had the highest rates of binge drinking. Next slide. All right, this slide looks at binge drinking among all Oregon adults by education, income, and health insurance status. And if you note, the populations that tend to accrue the most harms from drinking, and these are usually lower socioeconomic status groups, lower education, lower income, no insurance, and they actually have lower binge drinking rates. And this pattern is referred to as the alcohol harm paradox, where the individuals with lower socioeconomic status tend to drink at lower rates than those with higher socioeconomic status, but accrue more of the health harms. Next slide. So this one, at first glance, looks like a repeat, but it is looking at binge drinking among the same demographic groups, but this time it's limited only to current drinkers. The previous slide was looking at everyone, all adults. It was looking at all adults. And this slide is looking at only adults who drink. And so you will notice that by removing non-drinkers from the denominator, it flipped the chart. So we see higher rates of binge drinking among the lower socioeconomic groups. And the reason for this flip is because there are more non-drinkers in that lower socioeconomic group. So if we just look at current drinkers, removing all of those non-drinkers, we get this flip. We see the higher rates of risky drinking in the low socioeconomic groups, even though they drink less overall. And all of this is to say, alcohol consumption and the related harms are a complex story. There are many social, economic, and environmental factors that influence drinking behavior, as well as our ability to mitigate the alcohol-related harms. Next slide. Both binge drinking and heavy drinking have been trending upward over time. The increase in binge drinking has been primarily driven by women. Next slide. So this slide shows binge drinking by gender, so you can see the increase among women over time. So while women still have binge drinking rates that are lower than men, they have shown much greater change over time than men. So if you look at men's rates, the 2021 rate is not drastically different from the 2001 rate at 22.5 versus 22.7. However, if you compare the same years for females, we have a rate of 7.6 in 2001, and that goes up to 13.5 in 2021, and that's a 78% increase. Next slide, please. So while rates among adults have been increasing, we have seen declines among youth. Binge drinking among Oregon youth has decreased by nearly 50% since 2001. Next slide. So now we're going to look at death. Next slide again. Okay, so when we look at alcohol deaths, we often talk about alcohol-induced deaths and alcohol-related deaths. These sound the same, but there are slightly different ways to look at alcohol mortality. Alcohol-induced deaths, those are the deaths that can be considered 100% due to alcohol. The list here shows causes and cause codes that would fall under the alcohol-induced rubric. But you can see, and most of them have alcoholic in front of them or alcohol-induced. But like there would be like alcoholic liver disease, alcohol-induced pancreatitis, alcohol poisoning, those sorts of causes. Next slide. Alcohol-induced deaths have been increasing over time, and we saw a significant increase from 2019 to 2020. Next slide. Among the alcohol-induced deaths, most are due to alcoholic liver disease, and the next highest category is mental and behavioral disorders due to alcohol. Next slide. Okay, so when we look at alcohol-induced deaths, we can look at them by race and ethnicity, and we can see the American Indian and Alaska Native group has experienced higher alcohol-induced death rates than the other groups. The overall alcohol-induced death rate during this 4-year time period, if we were just looking at all race and ethnic groups combined, it's not on this chart, but it was about 19 per 100,000. So for reference, that's approximately, like if you look at the bar marked white on this chart, it would be about where that is. So you can see how much higher than the overall death rate it was for American Indian and Alaska Native. Next slide. So when we're looking at sex and age, you can see that men were more likely to die from alcohol-induced causes than women. And also those in older age categories had high rates of death due to alcohol-induced causes. You can see that 45 to 64-year-old age group has the highest rate, and then followed by 65 plus. And we may not always consider alcohol as a problem for older adults, but drinking rates among older adults are increasing. And alcohol is related to many chronic diseases that affect older adults. Additionally, older adults may have other risk factors. They may be more likely to take medications that interact with alcohol or have other pre-existing health conditions that make alcohol consumption more dangerous. Next slide. So the other way we look at alcohol deaths is alcohol-related causes. This is a broader concept, and that includes all of the alcohol-induced causes that we were just talking about. But it also tries to account for deaths where a portion of the deaths were due to alcohol. For example, a portion of cancer deaths are due to alcohol, as well as a portion of hepatitis deaths and a portion of motor vehicle deaths. This list has some examples of causes where some of the deaths are due to alcohol, but not necessarily all. The CDC has an alcohol-related disease impact, or called ARDI, application with a full list of these causes. And you can find all of the alcohol attributable fractions for each cause at that site. Next slide. So in 2020, there were 2,536 alcohol-related deaths among Oregon residents. And so if we were breaking that down into the 100% attributable or alcohol-induced versus the additional deaths using the fractions, 1,137 of those, about 45%, would be the 100% attributable or alcohol-induced causes, and the remaining 55%, 1,399 deaths, calculated using the attributable fractions. Next slide. So like the alcohol-induced death rate, the alcohol-related death rate has also been increasing over time. From 2011 to 2020, the rate has increased 30%. Next slide. And also, like alcohol-induced deaths, we see higher rates of alcohol-related deaths among men and older age groups. Although you can see in the older age groups, before with the alcohol-induced deaths, the 45 to 64 had the highest rate. Here, the 65 plus have the higher rate. And as touched upon earlier, chronic disease is really playing a key role here. Alcohol is associated with a variety of chronic diseases like liver disease, cancer, hypertension, heart disease, and stroke. So with an aging population, we see many harms increasing among the older age groups. And liver disease is actually even becoming more common among those in their 30s. So these types of alcohol-related harms, they're often overlooked despite a large contribution to the overall alcohol harms. So while we've seen huge successes in reducing underage binge drinking in Oregon, adult binge drinking has generally been trending upward. Okay, next slide. Again, this looks similar to what we saw with the alcohol-induced deaths by race and ethnicity. You can see again, American Indian Alaska Native group is overrepresented here with an alcohol-related death rate much higher than any other group. And again, it's not shown here, but if you looked at the overall alcohol-related death rate for all race and ethnic groups combined, it would have been about 45 per 100,000. So they're definitely overrepresented. And this is getting back to certain groups experiencing more harms just due to more stressors and structural disadvantages. These include racism, discrimination, economic disparities. There are lots of reasons that certain groups experiencing more alcohol-related harms. Next slide. And so this slide has some indicators I've already talked about throughout this presentation, but I find it useful because it combines onto one chart 3 of our primary indicators: the alcohol-related deaths, the alcohol-induced deaths, and liver disease death rates. So alcohol use, excessive alcohol use, has been a growing problem in Oregon for decades, much longer than is shown on this graph. It just shows 10 years, but you can see that all 3 of these indicators are on the rise. Next slide. So this gets into some attitudes and opinions on our Oregon Health Matters survey. Responses there show that 86% of Oregonians see alcohol as a serious problem. 45% said alcohol had been a cause of trouble for their families, and 65% of respondents said that they believed alcohol companies promoted acceptance of excessive drinking. Next slide. This slide lists out some external factors or social determinants of health. And it's just because it's important to note that there are multiple stressors and external factors that are impacting individuals and communities. And there are strong associations between many of these different social determinants of health and alcohol use. The harms associated with excessive alcohol use cross many sectors and issue areas. So in order to effectively address these harms, we need to work together on solutions across programs. Next slide. I believe that's Vicki again.
So that was a big fire hose of data and charts and graphs and numbers. I can we can pause here a little bit if there's any questions on the data, or we can kind of keep going. There's just a couple more slides that talk about policy and frameworks, but having to take a pause here for people's brains to sort of decompress a little bit, because that was quite a fire hose. But happy to take questions now, if there's any on data.
Hi, Commissioner Kelly Minty. Really super interesting presentation so far. I was really intrigued by the point about the something that wasn't necessarily instinctual related to the health impacts on the those in the higher socioeconomic status versus the lower, that the health impacts, if I recall, or if I got it right, were actually higher. And if you could sort of explain what the theory is on that relationship, that would be helpful.
Do you want me to take that, Vicki? Yeah, okay. So, yeah, and as said, it's called the alcohol harm paradox, and it is sort of complex because, you know, as you could see in those slides, if you sort of cut it different ways, it can look different and pull out different subtleties in the data. But the big picture is that if you just look overall, people with higher socioeconomic status characteristics tend to drink more. There are more non-drinkers in those lower socioeconomic status categories. However, when you look at harms, like when we look at our deaths as indicators, we see higher rates among those groups experiencing the harms. And there's not just one easy answer for like, why is this happening? And that gets back into like that last slide of like the external factors and the social determinants of health. And I believe even at the very beginning, Vicki had a slide listing out all these multiple interactions. They're different, like there could be geographic barriers that are more likely for certain populations, or maybe certain groups have better access to healthcare, or maybe their built environment is safer or healthier. Social supports is listed here. Just more ability to mitigate the effects of drinking in the higher socioeconomic groups. So yeah, I wish I could just say like there's one particular answer, but you know, it's probably going to vary from like which group are we talking about, even because each circumstance is different. Like each environment has different variables affecting it. Like, what is their work like? I mean, that's even a question you ask, like, what are the jobs they do? What are their working hours? Like, you know, I know I was just reading an article on like how shift work affects your health. And like, so say you are working a job where you have to work nights or weekend, and that's already affecting your health. And then you have like healthcare that's not as good on top of that. And you maybe have to drive further to get to your healthcare. That's going to all compound your ability to deal with alcohol. Just as an illness.
Yeah, I'll add to that, Alicia. So yeah, basically it comes down to the fact that those in higher socioeconomic groups have more resources to purchase and consume alcohol, and they have more resources to mitigate the harms of alcohol. And so that's why you kind of see that paradox there. I also try to describe it as like, you know, alcohol is really kind of like a fuel that gets thrown on pre-existing fires, right? And so if there's already more fires occurring in certain areas and in certain groups, alcohol is just going to like increase that fire. And, you know, again, people that have more resources to put out said fires or deal with those have better outcomes, despite the fact that maybe their fire is bigger, but they have more reasons to actually put it out, you know, like as Alicia said, it's very complicated and there's not a single straight answer, and it has all to do with kind of the social determinants of health as well. And so that's why we also have here that like real true alcohol prevention work is also social determinants of health work. They are very much interrelated.
Excellent.
Tony, oh, yeah, thank you for the question. I think Tony had a question too. I can't quite see all the hands that might be up, so.
Yeah, I did. Thank you, Victoria and Alicia. Going back to the slide that showed the spike in binge drinking rates among women, I'm wondering if there is some data that tracks that same time period that would show changes, if any, in things like cancers that are more commonly occurring in women, or other health outcomes that are more common among women or exclusive to women, just as we've seen this spike in binge drinking take place in that segment of the population.
Lisa, you might want to speak to maybe some of the cancer stuff that you might know about. But one thing I also like to mention in this slide, as we see this pretty dramatic increase among women, you know, and men have remained flat. And I think in some ways, you know, alcohol industry has realized that, and in any good industry in any capitalistic society is like, who can we sell our product to make more money, right? And so I think women have just been a target category of the industry. I think over the past couple of years, we've seen a lot of pink washing, so to speak, in the alcohol industry. There's a lot of products that have been geared towards women specifically that we're seeing on the shelves now. You know, I think like the you know, mom wine culture has become a thing. Like, I think the alcohol industry has really found a way to you know, tap into the things that women can identify with, and you know, market their products to them based on their experiences of being stressed because of motherhood. And like that is very interesting to me, and I do think that is one reason why we've seen this increase. Alicia, do you have anything to add in terms of like the specific health outcomes for women?
Well, I was going to say that is a really great suggestion. I actually wrote it down because I would like to look into that. I do know that there are definitely specific causes that I would want to look at. I know, like, for example, breast cancer is on our list of cancers that is affected by alcohol. I do know that the alcohol-related death rate for women has been going up in general, but that would include all of the causes. So I think it would definitely be interesting for me to pull out a few that I know specifically might be more likely to affect women and look at those. So that it's a good suggestion.
I would be very interested in your findings.
Yeah, I'd be happy to share those.
Any other hands or questions up right now? All right, let me get back to where we were. Sorry for the assault on your eyeballs here. To get to where we, okay. So big question, how can we address excessive alcohol use in Oregon? What the heck do we do? Just to go back to this illustration and show sort of this this graphic about the upstream approach and how we are going to definitely need strategies and resources at every area of this stream to impact this issue is what's needed. This is a big problem. It's going to require big solutions, again, at all levels of this stream here, not just improving community conditions. We also need to address individuals' social needs. We still need to address, you know, things like the alcohol outlet density. We still need to address underage drinking and drinking during pregnancy. All of these things impact the overall burden and context of alcohol on our society. But just to note again that this is a big issue that's going to require big solutions at all areas of the stream. I use this graphic to kind of help illustrate that. This is the substance misuse and addictions prevention framework. That's kind of like the inverted version of what you just saw in the stream. So kind of like at the bottom of this pyramid, the foundation that we want to build to help mitigate this problems is really those environmental controls and those social determinants. So increasing the price of alcohol, age restrictions, limiting advertising, increasing personal and community resilience, prevention of adverse childhood experiences. All of these things are going to need to be part of the foundation of this prevention work that we need to do to mitigate this issue. Sort of that middle area of the pyramid or of the stream, you can think about like chronic disease screening and management. So we need to continue and improve screening, providing treatment, removing stigma that's associated with having substance use disorders, and understanding of this issue as a chronic disease, really. And then sort of those, downstream approaches of preventing those life-threatening adverse health outcomes, and increasing access to treatment are the things that we all need to be doing to mitigate this issue. Again, it all needs to happen at the same time, all at once, right? Easy. Okay. And then I just wanted to share with you some of the things that the CDC community guide recommends for that really like top level area of the stream, bottom foundation of the pyramid, I guess you could say. So these recommendations are to increase the price of alcohol, regulate alcohol outlet density, commercial host liability. And that just means sort of like removing the, not removing, but like moving the penalties associated with like serving to someone who has overconsumed, moving that liability from an individual to a business or a corporation, avoiding further privatization of alcohol sales, maintaining limits on days and hours of sales. In many other states, for example, you cannot buy liquor on Sundays, and that has shown to improve health outcomes in those states. So days and hours and just limiting the time in which you can purchase alcohol has been associated with improved health outcomes. Continuing to enhance enforcement of laws prohibiting alcohol sales to minors. There's a lot of equity implications there as well that I think we need to consider. Improving screening and brief interventions. And then again, recommending against the privatization of alcohol sales. So these are the strategies that the CDC recommends. And this is what really applies to that top level area of the stream. I mean, we still need everything else. We need prevention of underage drinking. We need all of the strategies that the CSAP and SAMHSA recommends in those areas as well. And so all of it needs to come together and work together to help mitigate this issue. Oops, there's some animation there. All right. Okay. And then I just want to end by providing some resources to you all. The Public Health Division has an excessive alcohol use prevention website, which for now is sort of just like a compilation of links to other places where you can find resources. But this is where we envision sort of building out our portfolio of alcohol prevention resources. I think eventually this is where our alcohol outlet density dashboard will live. So bookmark this. Here's a link to the community guide to those strategies that were just on that last slide. There's also a link here to our section's chronic disease data portal. And here you can find a queryable tool where you can get alcohol, tobacco, and cannabis use information and query it by different demographics and also by county as well. And then also I wanted to point you to a resource that we have at our rethinkthedrink.com communications brand and website. There's a nice one-pager there as well that summarizes some of the health harms, health impacts, and it's in a nice visual way too. And I also encourage you all to revisit Rethink the Drink there for a lot of the information that we've presented to you today. I know that we've been here at the commission to present on Rethink the Drink, and I think in the future we'll be back to talk more about that brand and campaign as we wrap up our evaluation of the first campaign here in a couple of months. So those are the things I just wanted to plug for resources for you all, and then we have time for more questions. And I see other Tony has his hand up now. Hi, Tony.
Well, as usual, I pay to have to be present at your presentations. Fortunately, I get them for free.
Thank you.
I talked the recent reporting about the $1,000 bottles of bourbon, who knew there was bourbon for $1,000 a bottle, got me to looking at the Oregon Liquor Control Commission. And I'm looking at the list of things, if you put that back up at your last slide. Yeah, that one. Is there it is certainly not the case that the Oregon Liquor Control Commission is increasing alcohol, trying to increase alcohol taxes or regulate outlet density. And in fact, they're going to the delivery, the home delivery. And at our last meeting, there was a presentation showing that I think it was something like 40% of the home delivery, there was no assessment of checking ID. We're going in the wrong direction in this state. And I'm wondering what state agencies, if any, are doing anything that would actually lead to an increase in the alcohol tax, which is number one for very good reason. It seems to me that the attitude data that you showed indicates that there's enough public support that with the proper efforts, there could be something done about this. And I understand that the recovery group has created an organization that's working on that, but I'm interested in how we can address those risk factors in this state.
I think I will address that by saying that, while people understand that alcohol is a huge problem in society and that many people have been individually impacted or their families have been impacted by alcohol use, I think there's a long way to go to help people understand what the community level solutions are to those problems. Alcohol use disorder is still very much viewed as an individual problem. And many of the solutions out there are those individual level solutions. And so I guess I would just say for now, at least through our Rethink the Drink campaign, the long-term vision of that campaign in that brand is to help people move towards these solutions. That's not the answer probably that you want to hear right now, but I do think in the long term, maybe we can start moving people towards these types of solutions so that when legislation does get introduced at some point, there is more public support and public pressure on our decision makers to move these types of solutions along. I don't know if anybody else wants to say anything about that.
Just one comment. I think that the tobacco control movement is an example of how this could be done. And it can't be up to government alone because the citizens got to do it. But we need a lot more attention to this. And I think the commission should consider what it can do. I mean, when John Kroger originally created this version of the commission, he said, oh, no, we're not going to touch that. And no one has touched it. And the problems get worse instead of better. Thank you for your work.
Yeah. Thanks, Tony. Yeah, and I do think, people forget history very quickly. The Oregon Liquor Control Commission, they play a very important role. And I definitely think that, in the future and moving forward, our partnerships with them will be very important. So. Anybody else want to add anything? Yes, Jess. All right. Any more questions, comments, thoughts, reactions?
Can we get a copy of these slides?
Of course. I think, Jill, did you receive them? I sent them to you.
I did, and I can send them out with the slides from my presentation. And so, yes, everything that we've shown today can go out to commissioners.
Thank you.
Thank you very much for the presentation. Is there any other questions or final comments from commissioners on the presentation? Okay, I'm seeing none. So we will move on to agenda item number 5, which is public comment. Any members from the public who would like to speak? Give it a few more seconds. Again, any members from the public that would like to be heard? Okay, hearing none. Thank you all for attending. Executive Director, would you like to have any closing remarks?
Yes, and I'm so sorry. I don't have daycare today, and I have a very upset toddler in the background. So if you hear someone screaming, that's my 2-year-old who is having a moment. I just wanted to let commissioners and everybody know, we are trying to make next month's commission meeting, so the March commission meeting, really focused on workforce issues. So we are having a few different speakers. I think everybody remembers there have been several bills that have passed at the legislature that have tried to increase funding for diversifying and expanding the workforce, and several of those are being administered by OHA. So we have a couple of speakers from OHA to come in and just let us know how those bills have been implemented and what's been happening. And we also have we are trying to have Mokbo come in and talk a little bit about what they're doing for workforce. So I just wanted to make sure that everybody is aware. If you have any other suggestions about workforce issues, please let me know. We're really trying to make next month workforce focused.
Thank you, Jill.
Yeah, when is our meeting? Because I'm looking at my calendar and we have an extra Thursday. So are we meeting on the 23rd?
Yep. We are meeting on March 23rd.
Okay, great. Thank you.
Yeah, you're welcome.
Okay, everyone, we're going to give you about a half hour left in your afternoon. So thank you all for attending today, and be safe out there.